Hello, I'm Dr. Denise Smart. As a nurse for over 35 years, I have seen my share of work-related injuries. I have also experienced several work-related musculoskeletal injuries with recoveries requiring medication, physical therapy, and even surgery. This video is designed for nurses and anyone in the healthcare profession who has direct patient care contact. Many typical patient care activities are depicted throughout the video, demonstrating both proper and improper techniques. As a caveat, let me assure you, no injuries were incurred while filming this video. While we have provided many different scenarios, not all work-related injuries are discussed or presented. For the purposes of this educational offering, we are presenting only the most common musculoskeletal injuries. Let me be very clear, injuries can be prevented. In this video, we are not making the assumption that the injuries described are inevitable. However, injuries to nurses and other health professions that have direct patient care responsibilities are receiving national attention in the form of state regulations to address safe patient handling in all settings, including hospitals, long-term care facilities, and clinics. And now I'll turn the program over to our narrator as we consider the benefits of protecting nurses as a valuable resource.
75% of hospital nurses report that more than half their time is spent performing repetitive activities that put them at risk. The energy nurses expend in lifting, pulling, pushing, and twisting as a daily requirement of patient care can result in fatigue that places both the nurse and the patient at risk for injury. There is no safe way to manually maneuver a person. The knowledge and practice of proper body mechanics, which are useful for moving inanimate objects, do not apply to the task of lifting and moving people. The weight and mass of inanimate objects remain constant and predictable. Such objects may also come with handles to assist with proper and safe handling. But people can shift their weight, contort their bodies, and during the task at hand, change from helping to hindering. The use of body mechanics for patient handling is an insufficient approach for preventing musculoskeletal disorders and injuries. This program will define biomechanics, body mechanics, and ergonomics and examine their roles in nursing and patient safety. It will examine activities that increase risks for injury during patient handling and identify the most commonly reported injuries among nurses. It will demonstrate patient handling behaviors that put nurses at risk for injury and advocate the use of equipment designed for specific patient handling tasks. In general, this program promotes the need for developing a culture of safety throughout the career field. Biomechanics is the study of the mechanics of human activity and how muscular activity leads to internal loading of bones, ligaments, joints, and other soft tissues in the body. Internal loading can be thought of as cumulative trauma that results from repetitive stress. Along with internal loading, muscles, bones, and ligaments are subject to the concept of force, or the amount of physical effort required in performing a task, such as heavy lifting or maintaining control of equipment, tools, or patients. Body mechanics is a subset of biomechanics. It is based on a belief that reliance on correct body positions, or body movements, will provide protection from the force associated with lifting and moving patients. Body mechanics alone do not provide sufficient protection from the heavy weights, awkward positions, and repetitive motions involved in manually handling patients. Ergonomics is the science of fitting the job to the worker with an emphasis on reducing the problems associated with muscle and joint disorders. Environmental hazards may contribute to risks for injuries during any patient handling activity. Floors may be wet and slippery or uneven. Bathrooms and shower stalls may not be designed to accommodate both the patient and the caregiver. Obstructions may be present and not easily removed. Beds and chairs may not be designed to adjust to positions that enable nurses to perform tasks while adhering to the principles of biomechanics and body mechanics. Lifting, pulling, pushing, and twisting are 3 required activities that put nurses at risk for injury. Lifting patients is one of the most hazardous activities that nurses perform on a daily basis. The definition of a lift can range from helping patients sit up in bed
Oh no, let me help you up.
to helping a fallen patient get up from the floor. If a nurse lifts a patient every 15 minutes during an 8-hour shift, and the average weight for each patient is 150 pounds, then over the course of a typical day at work, a nurse will lift well over 2 tons. Back injuries among nurses may occur when a lift is repeatedly performed on a daily basis. Lifting patients without adequate help from staff or the aid of appropriate equipment may significantly increase the risk for a back injury. The actions of pulling and pushing while performing patient care contribute to musculoskeletal injuries by combining forceful exertion with awkward positioning. Over time, the repetitive actions of pulling and pushing, such as turning patients or transferring patients, may damage muscles, ligaments, and vertebrae. Twisting the trunk or torso in the act of performing patient care contributes to undue stress on muscles and ligaments as well as the spine. Ligaments can no longer properly support the alignment of the spine, and the vertebrae become unlocked, leaving the spine vulnerable to injury. Patient care activities often require nurses to lift, pull, and twist simultaneously. While working with patients in beds or chairs that do not meet good ergonomic standards, nurses are often required to hold static positions for lengthy periods of time. These activities may result in damage to the body, developing painlessly over time, or they may be the cause of an immediate career-ending injury. Symptoms of musculoskeletal disorders include pain that can vary according to the extent of the injury. The most commonly reported musculoskeletal injuries among nurses are low back injuries, shoulder or neck injuries, wrist or hand injuries or disorders, and lower extremity injuries. According to a study conducted by the American Nurses Association in 2001, of the nearly 5,000 nurses surveyed, 83% reported working with back pain. Back injuries may range from a mild ache with good recovery to career-impacting events. Disabling back pain has been ranked second in workplace health and safety concerns. Studies have confirmed that better than 1 out of 10 nurses leave the profession due to back pain. Most back injuries occur when a nurse attempts a task without the aid of proper equipment or adequate help from fellow staff members. Lifting devices may be poorly maintained or simply stored in inconvenient places. Staffing shortages can make teamwork difficult, or there may be an institutional culture that fails to recognize the importance of protecting nurses as a valuable resource.
I did not take care of my back when I was a nurse, a labor and delivery nurse. The nature of my injury was basically I took care of a large woman and had to hold her leg up for a very long time and sustained a torn muscle in my lower back as well as 2 herniated discs. In addition to her size, and so her leg was quite large, I didn't take breaks. I had not raised the bed to a point that was really safe for my back. I'm sure I didn't use my thigh muscles to sort of hold the leg in a good way using body mechanics. So I was really using my lower back. I'm sure I twisted, in these funny positions to try to hold her. And she was getting frustrated because it was a very long labor. And so I think I didn't take care of myself because I was so busy taking care of her and her emotional needs. So next, if I ever did it again, I would make sure that bed was at the right height. I would take breaks. I would ask other nurses to help me, take turns doing it.
The lower back is at risk for strains, sprains, and structural damage. A sprain is a stretching or tearing of ligaments that supports the back as it moves. Reactive inflammation with associated edema and local venous congestion develops within hours to days of the injury. Typical symptoms include pain and stiffness. A strain is a stretching or tearing of muscle. Symptoms are similar to sprains and include pain and stiffness, inability to use a muscle, and muscle spasm. High forces may generate structural damage to the spinal bones and discs that provide the strength and framework for the back. These types of injuries may lead to pain and acute or chronic inflammation of the ligament, tendon, muscle, or nerve. Eventually, scarring, stenosis, and degenerative changes can entrap tendons, nerves, and vascular tissues. At some point, the damage is irreversible and may require invasive measures to obtain a partial return of function. Tasks related to patient care may result in injuries to the lower back and spine due to the forces at work. The force placed on the back or spine due to the weight load of patients, unadjustable beds or chairs, and awkward positions nurses sometimes have to maintain during patient care all play a role in potential injuries to ligaments, muscles, and vertebrae. It is the vertebrae of the spine that provide form and support for the body. The lower back vertebrae are taller and bulkier than other vertebrae. This natural design of the human body accommodates the additional pressure from our own body weight and supports our daily actions such as lifting, pulling, pushing, and twisting. The spine is supported by ligaments and muscles, which are arranged in layers on the lower back. The first layer of muscle is covered by a thick tissue called fascia. The middle layer of muscle provides stronger support for the lower ribs, chest, and lower back. The deepest layers of muscles are located along the back surface of the spinal bones, connecting to the lower back, the pelvis, and the sacrum. These deep muscles work together with the muscles of the abdomen to help hold the spine steady during movement and work. Many back problems are a result of wear and tear. Even the normal aging process contributes to degenerative changes of the spine. Repetitive force and internal loading may result in cumulative damage and weakening of muscle layers. Normal, undamaged vertebral discs are flexible and firm. The center contains a viscous fluid, and this gives the disc its ability to absorb shock and protect the spine from heavy and repeated forces. Degenerative changes in the disc, facet joints, and ligaments may cause spinal segments to become painful and unstable. As a result, movement causes even more wear and tear on the spine and discs, increasing the chances of ruptured discs and pinched nerves. A disc that has been weakened or suffers an unexpected shock of force may rupture. If it ruptures, the material in the nucleus can squeeze out of the disc or herniate. Depending on the direction of the rupture, a disc may put pressure on a nerve root, causing significant pain. Even a normal disc can rupture. Repetitive bending, twisting, and lifting can place too much pressure on the disc, causing the annulus to tear and the nucleus to rupture into the spinal canal. Nurses may not be aware of the damage occurring to their spines because the nucleus of a spinal disc does not possess nociceptors or pain receptors. By the time the damage weakens the annulus of the disc and they experience pain, the damage is already done. Another type of musculoskeletal injury reported by nurses and other direct patient care workers occurs in the shoulder and neck area. The shoulder is the most movable joint in the body and is inherently unstable. It is easily injured by impact or simple overuse.
It was the kind of pain that I couldn't ignore anymore. And I began to notice it at work every day because I was doing repetitive behaviors at work. I was leaning over a rocking chair helping moms with breastfeeding, or I was leaning over the bed and trying to help moms in a really quiet, static cold. And so the leaning forward and extending my arm out every day would cause my shoulder to ache.
The shoulder joint includes 3 bones: the clavicle, or collarbone, the scapula, or shoulder blade, and the humerus, the upper arm bone. The bones of the shoulder are held together with tendons and ligaments providing additional strength and stability. The rotator cuff is a unique structure in the shoulder that is formed by 4 tendons. These 4 tendons attach to 4 muscles that help keep the shoulder stabilized in the socket, or glenoid, and help rotate the upper arm inward and outward. If the rotator cuff is torn and is not repaired, a type of wear and tear arthritis of the shoulder can develop over time. Injuries may occur due to normal use and overextended use of the shoulder during patient handling activities. The mechanism of injury results from the rotator cuff sliding between the humeral head and the acromion as the arm is raised. As the sliding occurs over and over, the rotator cuff tendons will often be pinched. This pinching is called impingement. Over time, impingement may lead to damage and weakening of the rotator cuff tendons. During the natural human aging process, shoulder tendons become weaker and blood supply to the tendons diminishes. This affects the recovery and healing process. The wrist joint is a complex joint formed between the distal ends of the radius and ulna bones and the 8 carpal bones. The wrist connects the forearm to the hand and allows for a good range of motion. Repetitive or forceful or sustained or even awkward use of the hands may, however, lead to injury.
With the fire code, the heavy door, we now had to twist a lever after we punched in a code. And this constant twisting, after using our hands for other things, this constant twisting going in and out of the nursery started to develop. We started to notice symptoms in other nurses as well as myself. Some of the nurses were having symptoms in both hands, some in one. One nurse even calculated on a night shift, not day shift, but night shift, that she was going in and out of the door 100 times in a 12-hour shift. This constant turning and pushing was increasing her symptoms. Several nurses decided to have surgery. I decided, rather than have surgery, to talk to the nurse manager about perhaps changing the door handles, going to the lever system versus the doorknob system. It took about 6 months for the doorknobs handles to be changed, and subsequently, for those of us that didn't have surgery, our symptoms diminished.
Of the 3 nerves that pass from the forearm across the wrist and into the hand, it is the median nerve that is affected by carpal tunnel syndrome, or CTS. The median nerve passes through the carpal tunnel and splits into 4 branches, supplying the sensation of feeling to the thumb, the index finger, the middle finger, and the interhalf of the ring finger. This is where the development of carpal tunnel syndrome occurs. In carpal tunnel syndrome, the nerves, blood supply, and tendons that run through the carpal tunnel get irritated and swell. Any increase in pressure within the carpal tunnel may reduce blood flow to the nerves, leading to the loss of nerve function and producing numbness in the affected fingers. Medical conditions such as diabetes, pregnancy, hypothyroidism, or tumors or cysts on the wrist may also generate carpal tunnel syndrome. Another musculoskeletal injury associated with patient-related care is injury to the lower extremities, particularly the knee. Knee joints are somewhat unstable structures, subject to articular cartilage deterioration and ligament injury. Articular cartilage covers the end of the leg bones, making the ends slick and able to easily slide over one another. It absorbs shock and provides a smooth surface to facilitate motion. The mechanism of injury to the knee is through slips, trips, falls, sustained awkward positions, and unexpected forces. There are 4 essential ligaments that provide support for the knee: the medial collateral ligament, MCL, the lateral collateral ligament, LCL, the anterior cruciate ligament, ACL, in front, and the posterior cruciate ligament, or PCL, in the back of the knee. The MCL and LCL prevent the knee from moving too far in the side-to-side direction. The ACL and PCL control the front-to-back motion of the knee joint. The ligaments, all taken together, are the most important structures controlling the stability of the knee. Menisci are special types of ligaments located between the femur and the tibia that help stabilize the components of the knee and distribute the force generated from the weight of the body. The menisci are thicker around the outside, and this thickness helps keep the round femur from rolling on the flat tibia. Without the menisci, the concentration of force into a small area on the articular cartilage can damage the surface and, over time, lead to degeneration. The mechanism of injury for many ACL ruptures is a sudden deceleration, hyperextension, or pivoting motion. Recent research indicates that due to basic anatomical differences, women run a greater risk of suffering an injury to their anterior cruciate ligament than men, and some studies suggest that women's ACLs may be weakened by the effects of the female hormone estrogen. As we have noted, there are numerous muscles, tendons, and ligaments that can be affected during the course of performing a job. While it is not possible to anticipate every potential source of injury, being aware of the most common injury sites and the tasks that may lead to injuries and the nature of the injury itself is the first step to creating a safe working environment. Patient transfers are common tasks and present a variety of hazards for direct patient caregivers. In this example, we see a nurse involved in the task of lifting a patient from the floor. Note the bent, twisted position of the torso, which places the lower back at risk for injury. The tendons in the right shoulder are at risk for strain, and the left knee is hyperextended. In this example of the same situation, the nurse is being helped by her staff members or by the institution's lift team. The full body sling is probably the most common lifting aid device. They may or may not be motorized, and they may be mounted on a portable base or on overhead tracks. No members of the team performing the task of lifting the patient are at risk for injury, and more importantly, the patient is not at risk. Here, the nurse is repositioning a patient in a bed that has not been raised to help her perform the task. Not only is she placing her lower back at risk, this maneuver places the patient at risk for injury. Now the nurse has enlisted the aid of a team member. The bed is raised, and they are using a friction-reducing sliding device to help reposition the patient. There is no risk of injury to anyone involved in this task. Current bed technologies have innovative designs to reduce the amount of slippage down to the foot of the bed experienced by patients when raising the head of the bed. Some beds can even convert into chairs, and other beds use air bladders incorporated into the mattress surface to help aid in rotation and patient movement. Daily activities of direct patient care require many repetitive actions that can place any part of the body at risk, but the primary hazard depicted in these scenes involves the hand and the wrist. Successful preventive actions for such conditions as carpal tunnel syndrome are exercise and attention to ergonomics. Some devices designed to support the wrist may help limit movement and reduce pain. In contrast to injuries occurred through immediate trauma or over time because of repetitive motions, are the hazards of holding static positions for lengthy periods of time.
As I was holding her leg, my lower right muscle in my back, I can't remember what it's called right now, it started burning. It felt like it was burning, and by the time I finished the delivery, I literally had to walk sort of leaning over because it hurt so bad.
3 to 4 years ago, I noticed that in my workday, I was, as I was bending over and helping with this 20 to 30 minute feeding, I would have pain running down my shoulder into my low back and numbness out to my fingers.
Although internal loading is usually associated with repetitive stress, cumulative trauma can occur while maintaining a static position. Due to individual human frailties, factors such as the weight of the load or the length of time a position is held are situational. Here is a routine patient transfer from a wheelchair to a bed. This has developed into a hazardous situation due to poor body mechanics, the improper height of the bed, the lack of a gait transfer belt, and the precarious reliance on the patient to help accomplish the task. The use of improper body mechanics has placed the nurse at risk for injury to the lower back, the shoulder, and the knee. However, the proper use of body mechanics by the nurse in this situation will do very little to assure the safety of the patient. Now the bed is at a proper height, and the nurse has provided a sliding board, allowing the patient to take a more active and safer role in performing the task, while substantially reducing the manual lifting required of the nurse to move the patient. Direct patient care involving these high-risk activities can be safely achieved, but all too often, the help or equipment needed to ensure the safety of both the nurse and the patient is simply unavailable. The majority of healthcare safety studies have focused on patient safety, and only recently has the focus shifted to consider the safety of the healthcare professional. To date, only a handful of states have passed safe patient handling legislation that requires hospitals and other healthcare facilities to provide policies or programs to reduce work-related injuries. States that do have regulations addressing safe patient handling have begun with research and support from large organizations such as OSHA or NIOSH. Recent research has motivated organizational leaders in healthcare facilities to recognize the value of fostering a safety culture within their institutions. Healthcare employees and patients benefit when policies encourage the development of safe patient handling committees. It is recommended that these committees, or teams, be comprised of interdisciplinary members to help fully assess facility needs. Team members may recommend the use of safety charts, palm cards, and patient handling algorithms. The team may research specific safe patient handling equipment and schedule training for direct patient care staff. Safe work environments exist when the use of patient transfer equipment and teamwork is routine, and all injuries and accidents are promptly reported.
Nurses and other direct patient care providers need to be aware of the types of injuries that have occurred in their facility and the frequency of those injuries. Remember, the best tool of all is your brain. Plan your patient care activities with the concepts of biomechanics, body mechanics, and ergonomics in mind. Recognize your limitations. Take responsibility for protecting yourself and your patient. Help develop a safety culture in your workplace and appreciate that you can have a long and healthy career.